There is no pain involved
Wow.
at all.
Are you serious, doctor?
The simple analogy would be, it's like having a blood transfusion.
When people hear about bone marrow transplant, they often think that's the last resort.
It's exactly the opposite.
How painful is it?
More recently, there has been something called haploidentical transplants, where we do half-matched transplants, which means potentially each and every patient can get a donor.
So you mean to say that there is still hope?
I think that's the new kid on the block. Put it in layman's terms, I can say it's your immune system on steroids. So I can say it's your repurposed immune system to kill the cancer.
My own immune system
Absolutely.
to kill the cancer that's in my body. If Google didn't exist.
Google doesn't give clarification. It's only the doctor that gives the clarification.
Hello everyone, I am Dr. Asna Zain from AM Health Hub, and today we have a very special guest with us, Dr. Thulpule. He is the Director of Hematology and Bone Marrow Transplant from Nanavati Max Super Specialty Hospital, Mumbai. So today's episode is going to be very special, Doctor. And firstly, thank you so much for allowing us to do this podcast. And as we all understand how sensitive this subject of bone marrow transplant is, it is both physically as well as emotionally very intense for anyone who has to undergo bone marrow transplant. So I would first want you to introduce yourself, and then we proceed with a few of the questions and we break myths regarding bone marrow transplant.
Sure. So first of all, thank you very much, Dr. Zain, for having me today, and it's a pleasure to be here. So as you rightly said, and for your modest introduction, I'm Dr. Thulpule. I am the Senior Director for Hematology and Bone Marrow Transplant at the Nanavati Max Super Specialty Hospital in Mumbai. And before that, I've basically did my medical education in Mumbai. Then I did my super specialty training, research in hematology, and was a consultant in hematology and transplant in the UK before coming back to India.
Wow.
I worked in one of the big super specialty hospitals there for 10 years before moving to Nanavati Max.
That's really good to know. I mean, that is something. I mean, like this kind of experience in hematology and bone marrow transplant is what we actually look for the patients who reach out to us at AM Health Hub. Because these patients, if I just want to brief you of what AM Health Hub does, is we get patients from around the world, doctor, who are struggling with a lot of diseases when it comes to, blood disorders. For example, sickle cell diseases, thalassemia, or AML, leukemias. And these patients are usually from Africa or Fiji, Mauritius, or different other parts of the world who seek or who have so many questions related to bone marrow transplant. They don't know which doctor to opt for. They don't know which hospital to go to. And having you here today with us, answering few of the questions that we hear from our patients is definitely going to be really helpful ahead. Doctor, let's start with the basics. When people hear about bone marrow transplant, they often think that's the last resort. And they also have this thing that, whether it is, only the adults who can go ahead with bone marrow transplant, or is it the children who need bone marrow transplant? So can you just throw a little light on who actually need it, and is it always the last resort?
Sure. Great opening question, Dr. Zain. And I'm really glad you asked this question. So contrary to popular belief, where people think it's the last resort and then do a bone marrow transplant, is exactly the opposite.
Oh, wow.
So the sooner you do the bone marrow transplant or earlier on in the disease, the better the outcomes.
Oh.
And typically, you would do a bone marrow transplant when the bone marrow fails. So as you know, blood is produced in the bone marrow. So you've got the red cells which carry oxygen, you've got the white cells which fight infection. Platelets are like sandbags in the blood. So if you've got a cut, the platelets go and plug the cut and the bleeding stops.
Sure.
So when the bone marrow fails, for example, in aplastic anemia, the hemoglobin drops, patients get breathless,
Yes.
the white cell counts drop, people get infection, platelets drop, patients get bleeding. So when the bone marrow fails, the sooner you do the transplant, the better the outcome. And there are other diseases in kids, especially thalassemias. You've got sickle cell disease, you've got immune deficiency disorders. So these patients, when you do a transplant, they get almost cured. In adults, you've got other things like lymphomas, multiple myelomas, you've got the leukemias, you've got childhood leukemias. So these are the sort of patients whom we would do a bone marrow transplant.
Doctor, you've just mentioned that certain diseases like thalassemia, sickle cell disease, that caught my attention because at AM Health Hub, we deal with a lot of African patients and their parents who are struggling with, acute sickle cell crisis and needing for hip replacements. And the journey is very tough. And they always come with this question that till when do we have to struggle, or till what, age do our kids have to struggle? And as you've just mentioned that it can cure the disease. Cure is a very big and a hopeful word for someone suffering with sickle cell disease. So can you just tell a little more about how long the treatment looks like and how will it be, for a patient from Africa having sickle cell disease? For how long do they have to stay in India for the treatment? Is there any preparation time required for that?
Good question, actually. So what I would say at the outset is the patients who have got their primary health provider, and typically the hematologists, I think it is best if they sort of reach out to a transplant center.
Mm-hmm.
The sooner the better.
Okay.
There are certain international guidelines in whom, should be transplanted. And typically these are patients with sickle cell disease who get sort of repeated crises and repeated pain, exactly as what you said. So these are the patients whom we would typically take for a transplant or offer them a transplant. Now, in terms of a donor, these types of transplants are called allogenic transplants.
Okay.
And as you rightly said, we use the word cure very cautiously because
I know
we deal with blood cancers, we deal with cancers of the immune system, cancers of the lymph nodes. So when we say cure, this is typically in the sense of a non-cancerous blood condition.
I understand.
So this is sickle cell disease, thalassemias. These are non-cancerous conditions. And it's a genetic defect because genetically they can't produce normal blood. And what it means is we select a healthy donor who produces normal healthy blood,
Mm-hmm.
and we change the immune system and give them a healthy bone marrow, which the patient doesn't have.
Mm-hmm.
So such patients, when they're referred early to a transplant center, typically the transplant will take about 3 to 4 weeks for it to be done in any transplant center. And then you have got at least maybe a week or so when you would actually examine them properly, make sure they're fit for transplant. And then post-transplant, we have to have regular follow-ups. And that really depends upon what the agreement with the local hematologist is, whether they're ready to look after the responsibility of the post-transplant care, or is it going to be shared care?
Okay.
Or typically it may be a couple of months, maybe 2 months or 3 months to stay, for example, in India
Mm-hmm.
after the transplant to make sure everything is fine.
Okay. So that's good to know, doctor. And now your answer had, popped another question. That is, you just mentioned allogenic transplant. So can we just put a light on how many kinds of transplants are there and which one is suitable for whom? Because if someone or some patient is looking at transplant, the first question pops up is, okay, which kind of transplant are we looking at and which one am I suitable for?
True. So broadly, we would divide transplants into two.
Okay.
One is autologous. Autologous means we use the patient's own stem cells.
Oh,
And typically we do this in conditions like lymphoma, which is a cancer of the lymph nodes, multiple myeloma, which is a bone marrow cancer, and in kids, something called neuroblastoma. So these are sort of the conditions where we would use an autologous transplant.
okay.
An allogenic transplant means we need a donor.
Oh, okay.
So a donor would mean family comes first. So typically we look at siblings who could be a full match.
Mm-hmm.
If not, then we can look at their parents if the patient is young. If the patient is older, we can look at their kids. Or sometimes we, refer these sort of reports or patients to an unrelated donor registry where there's a registry of voluntary donors
Okay.
who could be a potential match for these patients. More recently, there has been something called haploidentical transplants, where we do half-matched transplants, which means potentially each and every patient can get a donor. Because if you look at the inheritance of how genes are inherited, we inherit half from our mom, half from our dad, and the same thing we pass down, half to our children each. So which potentially means that if someone has got a condition and needs a transplant, but there's no full match, can get a half match from the relatives, near ones, who will be a potential donor for a transplant.
So you mean to say that there is still hope for someone who might not have siblings or the matching siblings for the bone marrow transplant? They still have hope ahead with the haplo transplant that you have just mentioned. Wow.
Absolutely correct, because the sibling may not be full 10 by 10 matched, as we would say it,
Yes.
but they could be half matched.
Oh, okay.
So they become a potential donor for the patient, which is very good news.
Oh, that is excellent. I don't think we were able to do this maybe 10 years back or 5 years back, doctor.
That's correct. I mean, previously, many years ago, when I was in the UK, there were centers who were doing haploidentical transplants, but the complications were higher.
Okay.
Until in America, that John Hopkins, they devised a very clever protocol so that the haplotransplants became successful.
Oh, wow.
That is widely practiced across the world, even in India. In our center is what we do.
That's great to know. That's really great to know. Doctor, I just want to know which are the patients who actually require bone marrow transplant.
Okay. So, as we sort of alluded to before, I think I would broadly divide them into two. So, those with blood cancers and those without blood cancer.
Okay.
Those without blood cancer, as we said, kids typically with thalassemia, sickle cell disease, immune deficiency disorders, these sort of patients need an allogenic transplant, which means a donor. And these patients can be cured. And if you do them in a center, with a lot of experience, you can get cure rates up to 85-90%.
Oh, wow.
So that's one subset of patients. Then you've got autologous transplants, which means you're taking the patient's own cells. So for that, you've got sort of relapsed lymphoma, multiple myeloma, neuroblastomas. Those form the autologous transplant.
Okay.
And then you've got the acute leukemias. So either high-risk leukemias or relapsed leukemias, something called myelofibrosis,
Okay.
or sometimes relapsed lymphomas, certain types of myelomas. You could consider allogenic or even a haplotransplant in those sort of situations.
Oh, that was very insightful as to who actually needs a transplant. Now, the most sensitive question that I would want to ask, and that actually comes from the patient side, is how painful is this transplant process? I mean, the process and the follow-up that goes on and the journey altogether post-transplant. How painful is it, or do they see the days going easy and pain-free after transplant?
Again, a good question. And again, a big myth.
Okay.
There is no pain involved
Wow.
at all.
Are you serious, doctor?
So there is no cutting involved. So when we say transplant, what patients think is we're going to take them to an operation theater, there's going to be some cutting, nothing of that sort at all. The simple analogy would be, it's like having a blood transfusion.
Okay.
That comes down to sort of that simplicity.
Oh, wow.
But it's not that simple either. So what we do is basically there are sort of three phases in a transplant. The first phase is where we assess the suitability for the transplant. So making sure the patient is physically fit, all the blood work is fine, all the organ function is fine, which means that they're suitable to be taken for a transplant. The second phase is when we admit them to the transplant unit. And this is the phase when the actual transplant happens. And again, you could divide this phase into sort of maybe two phases, where the initial phase is called conditioning, where we give them chemotherapy. And that specific chemotherapy, whilst patients are admitted for bone marrow transplant, is called conditioning chemotherapy.
Okay.
And we do that to sort of, you can imagine, to make space in the bone marrow to receive the new bone marrow.
Oh, okay.
So we give them, and that can be anywhere between 6 days to 9 days, can involve radiation as well. So that happens for the initial phase. And once that finishes, the next day or the day after, we infuse the bone marrow cells, which is like a blood transfusion.
Okay, and that can be both allogenic or autologous depending on the
Absolutely
condition.
correct. Absolutely correct.
Okay.
A few days after that is when the side effects of the chemotherapy that we gave kicks in. And that is like any other chemotherapy.
Understood.
So for patients for like leukemia, for example, if they've had leukemia, they've most certainly had chemotherapy before. So that is how we counsel them. Then it's going to be no different like the chemotherapy that you've had before.
Okay.
And in some instances, it is sometimes less intensive than the chemotherapy they've received before.
Okay.
So then they go through those sort of side effects that can last for up to probably a week or 10 days or so. That's the time when the bone marrow starts taking into the bone marrow, the stem cells,
Okay.
and they start forming the new blood. As soon as they start forming new blood, most of the symptoms disappear. And then the counts become better, they become more stronger, they're able to eat, walk about, and then we discharge them. So that this whole process takes about a month or so.
Okay.
Then after that, once they're discharged, then we have to follow them up closely. Depending on the type of transplant, maybe once a week or twice a week, depending upon what sort of arrangements we've had with the referring doctors, whether they want to do shared care. But typically we would see them in the outpatient department to, examine them physically, have some blood work done, look at the infective parameters, look at blood levels, functions, that sort of thing.
That's very good to know, doctor. That's very hopeful. In fact, what we hear, me as a doctor myself, I did not know the details of the process of bone marrow transplant. And as you have rightly mentioned, that chemotherapy is something that we see pretty often as a treatment option for most of the cancers. And if the side effects are in sync with chemotherapy, then we are not looking at something, out of the box when it comes to bone marrow transplant. Now, doctor, as you have rightly mentioned, that it takes typically 1 month of time when it comes to the entire process. Our patients would love to know about the post 1 month side effects, especially when it comes to infections. That is something everyone is scared of when they hear any word close to transplant, because there is immunosuppression involved. And so what are we looking at when it comes to bone marrow transplant, immunosuppression and infections?
Sure. I think good question. I think it's important for your listeners to know. So the risk is real. So I must say that the risk is real, but it's temporary.
Okay.
Okay. And I say that because they are at the highest risk when they are inside the bone marrow transplant unit, which means they are looked after 24/7. We really look after these patients like a hawk. Our nurses are excellent in, spotting all these things very quickly, which means we act very fast. And this sort of risk, or let us say a slightly higher risk, remains when their counts are low. And that happens when they receive the chemotherapy.
Okay.
And when they've received the cells and we are waiting for the counts to come up. That's the times, probably about 10 days or so, when they are probably at slightly higher risk of having major infections. Once their immune system recovers, once their counts recover, then, the risk of having problems due to, massive infections goes down drastically.
Okay.
So I think that's for any hematologist and transplanter, what we look for is something called engraftment. As soon as the counts come up, we all sort of breathe a sigh of relief. Good, the counts are up,
I'm sure.
And it's good for us and it's good for the patients. We tell them that, you're out of danger as far as major infections and problems are concerned.
Okay.
But as you rightly said, in some patients, like allogenic transplants, we have to immunosuppress them. But that immunosuppression we monitor. We monitor the viral infections, which can sort of raise their head, typically something called CMV infections, for example. And those can be dealt with. So to answer your questions, temporary but real risk when they're in the unit, but it can be dealt with. It's very short-lived, the risk period. And once they're discharged, we don't keep them in the hospital. They are at home.
And
we
Nanavati
can-
Max is definitely equipped to handle that
absolutely.
kind of,
Absolutely,
care when it comes to, controlling infection, the sterility and everything.
Absolutely. I mean, we see the patients. I mean, they go home and go about their normal business within reason. I mean, they're on a short leash. So we do call them pretty often, make sure they're absolutely fine, keep on reinforcing the precautions they need to take.
Oh, that's really good to know. Doctor, how about, any post-transplant patient and he comes to you asking that, is it possible that I lead a completely normal life henceforth? Is that possible? Is that a myth? Or do they have to make very drastic changes in their lifestyle post-transplant?
Okay, so that is not a myth.
Okay.
Patients can go back to their absolute normal, full working lives within months of having a transplant.
That's lovely to know.
Absolutely. I think that is what as transplanters we want as well. But yes, something that I tell my patients, sensible precautions. And it sort of sums up everything really. So obviously, you need to watch what you're eating, if food has to be cooked, if you're going out, try not to eat something that you're not very familiar with. Try to sort of restrict, not try new things. Don't go to crowded places. If you're going, wear a mask, but still avoid crowded places because you can catch viral infections, typical flus. What else? Have regular blood checks. That's important. If they have any symptom, which is even trivial, we tell them, please get back to us. Let us decide whether that is something that needs to be looked at or not.
That is a smart advice.
That is something, because they would say, okay, this is just a small rash, or I just had a loose motion, and we take everything very seriously. Just make sure that it's not any complication, that this is just a one-off and things like that. So we sort of keep them fairly restricted, but not so that it's encroaching on their freedom. We do encourage them, go out, have a
For
walk.
how long, doctor, if I may ask? For how
I think that after an allogenic transplant, probably the first 3 months. If someone's on continuous immunosuppression, then slightly longer.
Okay.
But patients sort of learn what, sort of they should be doing, they should not be doing.
something that they can inculcate in their daily activities.
And we encourage them. We tell them, you let us know what you want to do. You let us know what you want to eat. You let us know where you want to go. Just speak to us so that, we can advise you and guide you what you can do.
Got it, doctor. Now, I can't say last, but one most important questions for my patients across different continents. Why do we choose India for the transplant? Because that's a question from my end as well. Everyone, the most of the queries that I get at AM Health Hub is bone marrow transplant in India. And I'm telling you, from different parts of the world. They're seeking either they have their children for kids for bone marrow transplant, or adults suffering with leukemias. They all just eye India. So can you just throw a light on why is it India?
Sure, absolutely. So probably, as you know, that the healthcare delivery in India traditionally has been probably, private sector based. And over the years, there has been a lot of investment by, private hospitals into building really good infrastructure. As you're aware in the news as well, India's economy is booming, thanks to our, dynamic Prime Minister, Mr. Modi. And that has also translated in a lot of investment in the private sector, in the private health sector. And these are hospitals, which can match any Western hospital, which fantastic infrastructure. Brilliant doctors who have trained in the best of institutes in India as well as abroad. So you'll find a lot of doctors who have been abroad, trained abroad, have come back to India in this good hospitals or, modern hospitals with great infrastructure. The nurses are trained very well. Look at India's population. We see tons of patients with thalassemia, sickle cell, leukemia, so lots of experience. The food is excellent. The people are very
I
friendly.
cannot deny that.
Yeah, so I think if you're looking at all of these factors, I think then it becomes sort of a natural selection to sort of go to India. And the biggest thing, much, much cheaper.
I was about to say that. I
If you
mean,
consider
cost
other
being one of the
costs, if you
yes.
consider other costs.
I agree. I agree on that. So yeah, I now understand why people prefer India, because they get most of it under one roof, and the accessibility is something that amazes me of our Indian healthcare sector. I mean, it's so easily accessible, no matter what time of the day or night it is, or where are you from. I mean, your nationality, nothing matters. I mean, our healthcare runs 24/7, and it is not that we have to wait for months together for certain appointment with certain specialists.
I agree.
Yes. How we simplify this bone marrow transplant, it is a very intense journey, both physically and mentally, for not just the patient, for the attenders as well. What advice would you want to give to someone who is today considering bone marrow transplant?
Okay, I think good question and probably underemphasized, I think so. So, when we treat a patient, for example, let's say a patient has come with leukemia. It's a huge shock. Typically a patient comes from a middle-class family. He's the only earning member. The wife's at home. You've got two kids going into school. This is not an unfamiliar sort of scenario. And once this happens, the entire family is affected.
Yes.
And for us, as well as the patient and their family, it's like a journey together. Somewhere we do bond with the patient. And I think that's very important, because the patient looks up to the doctor, but at the same time, patients get intimidated.
True.
But, by asking a doctor, going and asking them. In that sort of situation, the family becomes their sort of go-to. Okay? We've got specialist nurses. They're much more happier to speak to a nurse, the clinical nurse specialist or bone marrow transplant coordinator with, things that they won't speak to us.
True.
The psychologist would be there. They form a bond. We have got our resident doctors. They form a bond. So it becomes like a small ecosystem. We've seen family members coming and speaking to us, but they can't speak to the patient because, they don't want to upset the patient. So we see a lot of dynamics, a lot of stress, a lot of, things where we definitely need, a psychologist or close friends, families, our nurse practitioners who form a sort of a group ecosystem within where, the patient is much more comfortable. Right from the word go, we also give them sort of written information. So we give them, safe websites where they can look at authentic information.
That is needed, doctor. That is so needed.
Otherwise, it's this Google doctrine, or, they read something up, they get scared. So we tell them, okay, go to this website. It'll give you good information. You won't get scared. We put them in touch with other patients who've gone through them, like patient support groups or patients who've been through it. And hearing this entire journey from them gives them a different perspective,
a different hope, and then confidence as well to go ahead and, take that dive.
Absolutely. Because over the years, what I've realized that those patients who are positive and have a strong mind, those are the patients who do very well.
Okay.
So, working on their mind, on their psychological health, mental health, keeping them at ease is absolutely important.
I'm sure. That's really hopeful to know about it. The kind of ecosystem that you have just described, it's like a support group. And, everyone, it's not just from the doctor. We have a nurse, we have a psychologist, we have the doctor, and then we are at a safe place. And I'm really glad that Nanavati Max Super Specialty Hospital has this kind of, doctors or the ecosystem and the nurses, where a patient traveling from a complete different continent, not just a country, continent, with just parents or a single parent, coming as an attender to a new country, to a new place, meeting the new doctor, feels that kind of safe and secure.
True.
So I'm really glad that, we know today that there is a place that exists, which can be opted for most of the patients who are looking for bone marrow transplant. Doctor, on a lighter note, if Google didn't exist, would a doctor's life be easier or harder?
Difficult question, but I'll say probably both.
Oh, really?
And I'll tell you why. If Google didn't exist, then it was me who would do all the talking. Then I will tell the patient, what the condition is, what to expect, what's going to happen, and so on. If they read Google and come to me, that means they've read something about it already. They have some sort of background knowledge. Okay, and then they come to me and ask, what's going to happen with my disease, what's happening, and you can make out, when you're taking the history, what do you do? Okay, they said we're a chartered accountant, and then they start using medical terminologies. Then they've read something somewhere, or typically it's Google, and they come through. It gets difficult when they read something about the condition or about, say, for example, low platelets, like ITP, for example, where there's thrombocytopenia, very common. It's immune thrombocytopenia or ITP. You give steroids, patient gets better, simple. But when they look at thrombocytopenia, it comes cancer and then bleeding and then death. And if they go into that sort of mindset,
It comes for an itch as well, doctor.
exactly, then it's difficult sometimes too, because if they start firmly believing in it, and then we have to say, no, it's not that at all. Come on. And they said, no, it's ITP. There's nothing wrong with you. Just go. And they said, are you serious? There's nothing wrong with me. Google said that it could be cancer. I said,
So eventually you mean that you can read up on Google but trust your doctor?
absolutely. So because Google doesn't give clarification.
Oh, definitely.
It's only the doctor that gives the clarification.
Agreed. Doctor, another question that, most of our patients are asking is, what is CAR T cell therapy? I mean, this is a question from my personal end as well. What exactly is CAR T cell? When do we do it? For whom do we do it? And what are the pros and cons? And what stage of development is it?
Wow, too many questions. But I'll try and answer this. Okay, so CAR T cell therapy, I think that's the new kid on the block.
Okay.
Extremely exciting,
Oh, wow.
both as for hematologists as well as for the patient.
Oh,
To put it in layman's terms, I can say it's your immune system on steroids. So I can say it's your repurposed immune system to kill the cancer.
my own immune system
Absolutely.
to kill the cancer that's in my body.
Yes. And now I'll go a little bit into more detail, but I'll try to avoid more scientific jargon. So what it is when patients get cancer, for example, let's say lymphoma, okay? Our immune system is built in such a way that the immune system or T cells, you've got something called immune surveillance, which is going on 24/7 in your body.
Mm-hmm.
So any cell that looks out of place, it recognizes those cells and, it destroys the cells, to put it very simplistically. Somewhere down the line, the cancer starts existing with that immune system,
Okay.
which means that something has happened and the immune surveillance has failed, or they're not able to recognize, and the body is tolerating the cancer.
Okay.
Now, whenever a T cell is one of the cells that kills other cells. You can say that, cancer cells. But it needs certain signals to do it. It can't just do it on its own. And cancer cells, for example, if you take lymphoma, or let's say specifically a B-cell lymphoma, they've got an antigen which, identifies them as a B-cell, typically CD19, CD20. Now, what happens is, once these patients relapse, if they've had chemotherapy, they've relapsed. So what these very clever scientists did is they took the patient's T cells, they took them to a lab, and they modified the cells in the lab. And they grew the cells, and they gave it back to the patient.
Okay.
And when they modified the cells, they made sure that it had a target against specifically that CD19 and 20.
Okay.
So as soon as cells were infused, it went and attacked the cancer, and the cancer was gone.
Interesting.
The initial trials were done in patients who had relapsed 3 times, 4 times, where, standard of care, there was nothing left to be given. And it is in these patients that they found good responses. So when there was absolutely no hope, CAR T cell therapy gave them hope. And there were more trials to see if we can use them sooner, in earlier lines. So to answer your question, yes, CAR T cell therapy is the future. We use it typically for relapsed B-cell lymphomas, relapsed B-cell ALL, acute lymphoblastic leukemias, for multiple myeloma.
Okay.
And mind you, typically when patients relapse, the standard of care has been to give them salvage chemotherapy and do an autologous transplant. But to do an autologous transplant, you need to have certain fitness. And typically, if you've got an elderly patient, they're not going to withstand that conditioning of we talked about
True.
for a transplant.
They're not fit in as an ideal transplant.
But they can be fit for a CAR T-cell therapy.
Okay.
So it's an interesting field. We've got 2 products in India at the minute. And again, cost is huge. It's probably 1/10 the cost of what it would be in the West.
Okay.
So it's an exciting field. So these are typically B-cell malignancies, lymphoma malignancies, leukemias, and multiple myeloma.
And we do this at Nanavati Max
Absolutely,
Super
we do that
Specialty
at
Hospital,
Marrow
Mumbai.
Max as well.
Oh, okay. That's good to know, doctor. I mean, like really exciting information here, and hopeful as well. And to finish our conversation, doctor, I would just want you to give some kind of advice that is, that can be given to a post-transplant patient who has had a successful transplant and is now watching this. What is that one advice that you would want to give to that patient? And then we come to the patient who is looking for transplant.
Well, I would ask that patient to give advice to other patients because he's been through it. No, but if I were to speak to him, or I wouldn't say advice because we've had a lot of advice. But what I would say is, well done. He's done absolutely brilliantly. But don't sort of stop going for your follow-ups.
Agreed.
Still be careful. As I said, sensible precautions.
True.
Spread the good word, because you never know who would require more psychological help, more information. Go form a support group.
Exactly. Support group. That is what we were looking at.
Form a support group because that will help a lot of patients who are looking for a bone marrow transplant.
I'm sure. And what about someone who's actually looking into the prospect of bone marrow transplant?
Well, I would say it gives hope. It's potential cure and a chance for a second life. Patient selection is important. The timing is important, and an experienced center is important. So look at those 3.
Thank you so much, doctor. It was wonderful having you with us and sharing certain information about bone marrow transplant, which is such a hidden chapter, and not everyone is aware of all that you have just mentioned. Thank you so much.